Hey, what's up, everybody? This is Sean, and we got
Hey
Hunter.
guys, how's it going? You're back?
We are back with our next broadcast. Hold on, I just gotta make sure that this thing isn't gonna like blast me out. There we go. Awesome. We are good to go. How's it going, buddy?
Good, man. How are you?
I'm great. What are we doing today?
We
Hmm.
are going to do an introductory, per se, basic oxygenation ventilation, kind of segueing into some bigger things we're working on. So, a good introduction on some of these concepts. We're not going to get too in depth. But yeah, I think it's a good review for everyone and people that are starting out with vents. It's super helpful.
Totally agree. Yeah, Hunter has been like rocking it. We've got a super cool guest for next week, right? Next Thursday.
Yes, yes,
So
yeah. We have the respiratory coach coming next Thursday. A guy that I've learned a lot from, respiratory therapist, that's agreed to come on, and we're going to dive in definitely a little bit deeper into some concepts. So yeah, it's gonna be sweet.
yeah, that's super cool. I can't wait. I'm so stoked about that. That's going to be awesome. So, yeah, so next week, there'll be three of us lined up. That's going to be crazy. All right. Yeah. So, we're
A
going to
lot
be talking.
going on.
What was that, buddy?
I said there's gonna be a lot going on.
Yes, that's for sure. Yeah. So, oxygenation, ventilation, and then talk a little bit about driving pressures and ARDSnet and all that stuff, lung protective strategy. Just giving it a few extra minutes for people to pop in. Um, if you are watching out there in social media land, so what our Facebook groups, the YouTube channel, um, leave a little comment. Send me a comment or send us a comment in the comment section. It will pop up, and I can share that with the broadcast. And just let us know who you are, where you are coming in from, and we can say hello. Unfortunately, as of right now, if you were watching it on the website, flightcrit.com, we cannot include those chat comments, but you can always head over to the Flightcrit group or the Flight Crit YouTube channel and leave us a comment. So just say, hey, let us know where you're calling from. Looks like we've got half a dozen people popping in so far, so that's pretty cool. Um, yeah, I don't have anything else to say. Hunter and I are working on a lot of new content right now, so we're super stoked about that. A lot of the stuff that we have, we're going to be repurposing back to the website. So for those of you who are joining the Medical Lab, our membership community, there's going to be a ton more stuff being dropped in there here soon. All right. Anything else you want to add, buddy, before we get going?
No, I'm ready to do it.
Let's do this. All right, let's go. All right, so let's get rolling here. Oxygenation, ventilation, driving pressures. This is kind of what we're going to be talking about today. When I say driving pressures, really what we're doing is we're just kind of talking about lung protective strategy and introducing driving pressures. I mean, most people have heard about ARDSnet protocol and low tidal volume ventilation to protect the lungs. This concept of driving pressures or keeping the driving pressure low to protect the lungs is kind of a hot topic right now. So we're going to chat a little bit about it, and then next week when we have the respiratory coach on, we're going to really hit that hard, talk about compliance, static and dynamic, and so on and so forth. But without further ado, let's do this. All right. So basically, what we're going to talk about real quick is a little bit of anatomy and physiology. And before I forget, stick around to the end of the broadcast because we're going to throw up that QR code for you guys to get your free 1 hour of continuing education. So stick around to the end, you'll catch that QR code. All right. So respirations, ventilations, oxygenation, right? Three very different concepts. We need to understand all three of them so that we, are can provide the best care to our patients, right? So respiration is nothing more than the mechanical movement of air in and out of the lungs. Right? Ventilation is that transfer of CO2 from the blood out of the lungs or out of the body, and then oxygenation, taking oxygen in and then delivering it to our blood and then to our tissue. So those are the kind of concepts we're going to be chatting about today. The big deal is this is just all about our gas exchange, right? And so in order to understand this concept of gas exchange, we need to have a fundamental understanding of what it is that moves gas in and out of the blood and the alveoli, right? So basically, just to kind of break it down very simply, right? the atmospheric pressure at sea level, and we will use this as just like a benchmark, is 760 torr. 21% of that is oxygen, so you multiply 760 by 21, you get about 160. You lose some of that oxygen pressure as the oxygen moves through the nose down into the alveoli, and it's affected by water vapor pressure. So by the time the oxygen gets into the alveoli, the pressure, the partial pressure of oxygen within the alveoli is about 100 torr. Okay. When you compare that to the partial pressure of oxygen within the arterioles, or right at that alveolar capillary membrane, there's a pressure of about 30 to 40, right? So it sets up this pressure gradient where the oxygen that is here within the alveoli wants to move into across that alveolar capillary membrane and diffuse into the blood to be picked up. And the same type situation occurs with Venus, right? The percentage of carbon dioxide in the atmosphere is about 0.04%, right? You could do the math. It's a very low partial pressure of CO2 within the atmosphere. And likewise, then, when that gets down into our alveoli, that partial pressure is very low. Our bodies produce carbon dioxide as a byproduct that gets transported to the alveoli, where then it is, to the alveolar capillary membrane, where it then diffuses very rapidly into the alveoli for ventilation, right? So that's just the down and dirty. We talked about oxygenation and ventilation there and how those two functions work. There's a lot that can go wrong, and there's also a lot that we can do to manipulate both of those in our patient whom we are assisting, whether it's intubated or non-invasive. Anything to add to that, Hunter, before we move on?
Nothing.
Cool. Right on. So, before we can actually start treating our patients, we need to understand what kind of problem they're having, right? There's two types of respiratory failure. There's a type 1 respiratory failure, which is failure to oxygenate, and there's a type 2 respiratory failure, which is failure to ventilate. That's all I was going to share, with this slide, is just that you need to be able to recognize which type of respiratory failure our patient is suffering from, and we can do that by looking at the gases, or for the most part, we're really going to just have a general idea when we look at them initially until we really start getting, more deep into the pathology, the pathophysiology of their disease process. So again, just a real quick overview: oxygenation versus ventilation, right? We manipulate either of these, in different ways. So primarily when we talk about oxygenation, we're talking about manipulating their PEEP and their FiO2. And when we talk about ventilation, or the manipulation of their CO2, we're talking about manipulating their tidal volume and their respiratory rate. And the goal here is to address their minute ventilation, right? Hunter, you want to add anything to that?
Yeah. No, I think so. Going through the two concepts, I think starting with ventilation, I think ventilation is a little bit harder of a concept to grasp, and we're about to dive into that versus oxygenation. We'll talk about the two differences, but yeah, no, I totally agree.
Cool. Well, why don't you go ahead and talk about ventilation, right, and how it is that we manipulate these, and what our goal is, and how we actually address this when we're setting our patient up on the ventilator and really trying to manipulate the ventilation side of this equation.
Yeah, so ventilation, guys, is a component of a few things. We have our ventilatory rate, or respiratory rate. We have the volume going in and out of our patient, which is our tidal volume, and then we have our minute volume. I think the most important concept is that minute ventilation, or minute volume, that encompasses both the respiratory rate and the tidal volume. So if you remember, normal minute volume or minute ventilation for a patient is about 5 to 8 liters. We get that by multiplying our rate by our tidal volume. We'll go into rate and tidal volume here in a second. But that is a thing you want to assess on your patient and know what minute ventilation you want to achieve. in order to set a correct ventilatory rate and tidal volume. There are instances that you'll want a higher minute ventilation for certain disease processes if you're dealing with a metabolic issue and stuff like that. The minute ventilation also a lot of these things I just tell you are kind of personal things that I do that are helpful. So if you do 100 times the patient's ideal body weight, you'll get a number in milliliters. So if you're 80 kilos times 100, that's 8,000 milliliters. And that's what we're shooting for a minute ventilation. If we divide that by our tidal volume, we'll get our expected rate. So if you're ever just like, I don't know where to start on a rate, if you do that equation, you get your minute ventilation, you divide by that tidal volume, you can get an expected rate. So if do you want to, we can just go to the next slide and kind of talk about
yeah, totally.
Start going into ventilation. So tidal volume is 6 to 8 cc's per kg based on ideal body weight. Now the book would tell you is this equation. It's 50 plus 2.3 inches or times inches minus 60 for men, and then 45 plus 2.3 times inches minus 60. So what I want you to do next time you have a patient is run both those equations and see how minuscule of a difference it is. I mean, we're talking, and I'm talking adults here, not pediatrics. But if you're doing ideal body weight on these adults and you see how small of a difference it is in the actual tidal volume, it's nothing. So what I do is I kind of just go with the 50 because it's a nice even number. I drop the 0.3. So I do 50 plus 2 times inches over 5 foot. Okay. So I can do that pretty quick in my head. So if you're a 5'2", so that would be 2 times 2 is 4 plus 50 is 54. And that number times 6 or 8. So I tell people that you can also round down or round up. I don't think, again, if you do this math next time with a patient, you'll see how little of a difference in tidal volume it is. So if my ideal body weight was 54 kilos, I would just call it 50 because I know 6 times 5 is 300. So I know at 6 cc's per, I'm looking at about 300. I always tell people to try and calculate in your mind what your upper limit of tidal volume is and what your lower limit of tidal volume is going to be on a patient that you're going to see. That way, if you get into an ARDS criteria, you're getting into a patient that's difficult to ventilate, difficult to oxygenate, you know your range and where you want to be. So you can come down on that tidal volume. So if you calculate your 4 to 8, if you want to go that low, then you know your range. You know as low you can go and as high as you should be able to go with that patient. But again, I do that 50 plus 2 times inches over 5 foot. And I just round down or round up. You know, we do the same thing sometimes in medicine. So I do the rounding with that. And it seems to help out a lot in my eyes.
Yeah. Totally agree with you. Yeah. Totally agree, right? Because remember, this is a starting point, right?
Right.
I mean, we're half the time we're estimating our patient's height anyways. Right? So we're going to be kind of in the ballpark, if you will. So I think that's great. You know, it makes it really easy rather than having to kind of pull out your calculator or whatever. You can do it super quick.
Right. So keep that in range with having, keep that in mind with having the range of your tidal volume. So you know your max and you know your minimum, and then you know how to get your minute ventilation. And I want to restate that minute ventilation is the number we are caring about. That is how we get CO2 off of the body. That is how we ventilate our patient, and we help with oxygenation. So that minute ventilation number that you calculate in your head, you want to know what it should be for your patient size, and then you can calculate how much tidal volume you'll need and such. As far as the rate, we'll talk about I/E ratios here in a little bit. But again, I gave you that little tidbit on how to calculate that rate. If you know your respiratory rate times your tidal volume equals minute ventilation, if you divide minute ventilation by tidal volume, you therefore get your rate. There are times that you want to decrease or increase that rate. We're talking about our obstructive patients and our patients that we're trying to blow off CO2, whatever that might be. But I just think it's a nice little way if you're just, some people are just sitting there like, where do I start the rate? And I just kind of give them that little tidbit. So,
No, I think that that's great, right? Because we've got charts to figure out where we start with our tidal volume. We kind of apply that as well if we're pressure ventilating, sort of. But yeah,
right.
there's we kind of always say we're going to start somewhere around 5 to 8 on the PEEP. But I feel like often we just kind of throw a number out there, when it comes to respiratory rate. Maybe we look at what their intrinsic respiratory rate is. But I think that's a really good point. So just to kind of recap real quick, you said 100 mLs times their ideal body weight gets their minute ventilation, and then you divide that. I'm sorry. That gives you
You're right.
100 times their ideal body weight gives you their minute ventilation,
Yep.
and then you divide that by your tidal volume to get a predicted starting respiratory rate.
Right. Yeah. If you just take that equation, your rate times your tidal volume equals minute ventilation, relatively 100 per. And again, this is just personal opinion, but 100 per. If you divide that minute ventilation calculated by your tidal volume, yeah, you'll get a relative starting rate.
Cool.
And vice versa. If you do that divided by the rate, you'll get your tidal volume.
Right.
So,
perfect.
But at least you can calculate the tidal volume yourself. So.
Yeah, because this formula here, the 50 plus 2.3 times height in inches minus 60, like it just seems so unnecessary, especially the throwing in the minus 60 part, right? I mean, that's 5 feet. Why even bother? Just, you simplify things.
Yeah. And then the pounds is even, I think, more difficult for males. It's 106 plus 6 for every inch over 5 feet, if I remember. And females is 100 plus 5 for inches over 5 feet. So they're both just, I don't even know, they're both just difficult, I think. And I just round, I mean, like I said, this is adults only, but I just started doing the math one day and I rounded from 52 to 50 and times that by 6. And I was like, oh, I mean, we're talking like 40 cc's,
Right. Yeah. Yeah.
So.
Same goes for like titrating your oxygen, up and down for atmospheric pressure changes. Right. There's a whole formula for that, but I always say just turn it up a little bit.
Yeah.
Yeah.
Right.
Because
Exactly.
the change is so minuscule. Yeah. Cool. All right. Here we go. So talked a little. This was just more kind of looking at dead space.
Sure.
And volumes, and so I don't know. Do you want me to talk a little bit about this, or we're going to come back to this when we get to dead space ventilation?
We can go. We can talk a little bit about this one.
Basically, what we were just trying to show here is that we'll come to it again when we talk about dead space, which is coming up in the next section. But keep in mind, like your dead space ventilation, your physiologic dead space, for the most part, it doesn't change, right? There's, you got your alveolar dead space, you got your anatomical dead space, but then when you start adding in, your ET tube, your vent tubing, your HMEs, your bacterial filters, your end-tidal CO2, inline connectors, your ballards, all that stuff, that all adds to your dead space, and your dead space doesn't change, right? So the idea, like Hunter was just talking about, is that your tidal volume is your respiratory rate. I'm sorry, your minute ventilation is your respiratory rate times your tidal volume, and if we're going to come down or up with one of them, then it's kind of like that seesaw effect, right? Because your minute ventilation generally should be the same. So if you're trying to keep your minute ventilation the same and you come up with your tidal volume, or you're down with your tidal volume and up with your rate, that's going to keep you in balance. But remember, if you are increasing your rate, that dead space ventilation is still the same. So the dead space ventilation ratio eventually gets to a point where it actually has a significant impact on your patient's ability to ventilate. Eventually you reach a point where you're just simply moving air in and out of a dead space. You're not actually providing alveolar ventilation. And if you do this formula, in this particular example here, right, this is a tidal volume of 600, 150 of it is dead space, 450 of it is actually reaching the alveoli at a rate of, call it, 5. But if you were to do this same math, figure out whatever your minute ventilation is, and then multiply that rate out, say it's 30 or 40, keeping the same dead space, you would see that your actual alveolar ventilation volume drops precipitously. Oh. All right, buddy.
Right.
And so, getting into dead space, and the whole purpose of what we were just talking about with doing these calculations to determine what the proper ventilatory volume is, or your tidal volume, and using that ideal body weight. I'm sure many of you have already seen this. It's because we don't want to be using the patient's true body weight, because as this picture describes or illustrates, the size of the lungs doesn't change based on the patient's true body weight or actual body weight. So that's why we use the ideal body weight, which is based on their height. That is the whole purpose of illustrating this. So keep that in mind. All right, dude. Dead space. It's yours. Go for it.
Yeah. So Dead Space, I feel like we all like talk about it, but it's nice just to really understand it. So Dead Space is comprised of physiologic dead space, which is actually both anatomical and alveolar dead space. So everyone in this world has a degree of anatomical dead space. Now, not everyone has alveolar dead space, and I'll explain how that works. So the average person has about 1 cc per ideal body weight based on pounds of dead space. And remember, anatomical dead space is the areas of the respiratory system that is moving air, but it's not participating in gas exchange. So that's like our pharynx, our trachea, our larynx, into the main bronchi, even into like the terminal bronchioles. So there's no gas exchange occurring. It's just a way to move the air. So starting out with anatomical dead space, 1 cc per pound of ideal body weight is the amount that is not participating in gas exchange. Another good way to do it is you can just say 30% of your tidal volume relatively is not going to participate in gas exchange. So for instance, if your tidal volume is set to 500 and your patient is going to be 100 pounds, I guess you could say, then 100 of that is not participating in gas exchange. So it's anatomical dead space. So 500 minus 100 is only 400 of that tidal volume is going to participate in gas exchange. Now, normal anatomical dead space should be about 20 to 40% when you look at the ratio of your dead space with your tidal volume. When you divide those two out, that should be about 20 to 40%. When that becomes more than 40%, then we get into an alveolar dead space. So again, everyone has anatomical dead space. Alveolar dead space now is where we get into patients with VQ mismatch, which we will cover. So those VQ mismatches are those areas or those alveoli that are not being ventilated or not being perfused. So they're not participating well in that gas exchange. So again, that physiologic dead space is going to be both anatomical and alveolar dead space. Everyone has the anatomical dead space, which is 1 cc per pound of ideal body weight. That alveolar dead space does not come into effect until you have a hypoxic issue. And we'll talk about VQ mismatch being one of the most common causes of hypoxemia, not hypoxic, hypoxemia. So if you have the run-of-the-mill overdose patient that's intubated for airway protection, or a head injury with no injury to the thorax, or any chest wall injuries or anything like that, you can almost assume that your physiologic dead space is your anatomical dead space because there's no alveolar issues. Now, if this patient starts to have issues with oxygenation and ventilation and they start to have hypoxemia, you can assume there is alveolar dead space as well. So those are the two big ones that we remember. And if you just remember one per your body weight in pounds with ideal, or relatively 30% of your calculated tidal volume, if you divide those two, you like that around the 20 to 40%. When that starts to become more, you're asking yourself, where is that volume going? And you're worried about alveolar dead space at that point. And then, we were talking about, there's also mechanical dead space. So patients that are we have positive pressure ventilation, we're losing that in the tube, we're losing that in attachments, and other things like that. So we have that anatomical, we have the alveolar dead space with our sicker patients, and then we also have the mechanical dead space, which is based on the, I don't know, Sean, it's based on the actual, you brought it up here. It's based on what we're using. So as you can see on the screen, how much volume you're losing in these certain things. So
Yeah,
um,
it's shocking when you actually start like just taking a syringe and start filling these devices with water. You see how much volume they actually will take. Um, you see
right,
that mechanical dead space adds up really quick.
right, yep, and obviously, guys, this becomes a huge issue with kids when we're putting a lot of attachments on there and stuff. And we're talking about volume currently, just FYI. But yeah, that becomes an issue if you're ventilating someone and they look like they're having signs of hypoventilation, whether that's a PaCO2, you're getting a venous blood gas, or if you're trending urine titles, then this becomes an issue of dead space, and you have to ask yourself, is this a VQ mismatch or some other portion of dead space? So.
Nice, cool, man. That's super
Like that,
useful.
Sean? You got anything on that, my friend?
No, that was pretty solid, right? Of course, when we, like you said, when we start seeing a patient who's not responding the way we expect, they're not off gassing
Right,
or they're not oxygenating, right? We got to think
right,
what's going on, and oftentimes it's a problem with dead space ventilation or shunt, which kind of creates dead space as well.
sure, right.
Right
I
on.
agree.
Um, Sweet. That was ventilation. So let's talk a little bit now about oxygenation. And obviously we all know that these topics they blend together, right? Just because we're now moving on to oxygenation, right? Everything works together, right? So
Right,
um, you know, let's talk about oxygenation. Right? So oxygenation is primarily affected by PEEP and FiO2, right? And we can manipulate mean airway pressures as well to improve oxygenation. But there's all kinds of gas, there's all these gas laws out there. Dalton's law is one. Um, um, Graham's law is one that people will often refer to when they're talking about oxygen diffusion, right? And it has to do with pressures. But very little people talk about Fick's law. And I think Fick's law personally is the most important law that we need to understand because it it is kind of the essence of what we are manipulating when we talk about increasing FiO and FiO2 and PEEP in these patients, right? So let's go ahead and break this down for a minute. So Fick's law is the diffusion rate of gas across a membrane, right? And basically, what all this is saying is that as the membrane is stretched, right, the rate of oxygen diffusion is proportional to the difference in partial pressures, right? So as we add more PEEP, we're increasing the pressure within the alveoli. We're also increasing the partial pressure of oxygen when we increase FiO2. Right? It's proportional to the area of the membrane, right? So if we now take an alveoli and we stretch it and we hold it open with PEEP, we are enlarging the membrane surface area. And then it is inversely proportional to the thickness of the membrane, right? So as I demonstrate in this picture here, when this balloon inflates, we actually get an increase in surface area as well as the wall of that balloon thins out. And if you've ever taken a balloon and you've blown it up as big as you possibly can before it breaks, you'll notice that that membrane gets really thin, right? So when that membrane is thin, the oxygen can move across it much quicker. We have more surface area for oxygen to, kind of pass through, right? Because oxygen's got to move through that very thin membrane. And then by adding the FiO2, we're increasing the partial pressure of oxygen. And so when you think about it this way, it makes sense why increasing PEEP and increasing FiO2 has the most direct effect on improving a patient's oxygenation, assuming that we don't have, like a shunt or a dead space ventilation situation, right? Likewise, if we talk about mean airway pressures, right? Mean airway pressure is what is the pressure over the entire respiratory cycle, right? And we know that the inspiratory pressure, if you think about BiPAP for a minute, the inspiratory pressure is always higher than the expiratory pressure. So if we prolong the inspiratory phase, we basically, make it so that the patient, the airway pressures, the pressure in the alveoli are higher for a longer period of time. Those alveoli are not only held open by PEEP, but they're also expanded longer during the inhalation phase, so we get more oxygen diffusion. There's more time for that oxygen to diffuse across that alveolar capillary membrane. So when you think about it that way, it makes a lot of sense why improving PEEP and improving eye time improves oxygenation. And likewise, there's some effect on ventilation as well. If we're holding those alveoli open, the CO2 can diffuse across that membrane faster. And again, there's a larger surface area. Just because we apply this to the concept of oxygenation, right? Fick's law doesn't just say this applies to oxygen. It applies to all gases. And so CO2 can diffuse across that membrane faster. Also, there's more surface area as well. So, and likewise, if we are hyperoxygenating the alveoli, think about what we do when we are preparing a patient for RSI, right? We do that big nitrogen and CO2 washout. We give them plenty of oxygen, 100%. We flush out all gas from those alveoli, except for oxygen. We're setting up a really pronounced partial pressure gradient. So all that CO2 can flush out of their system, and all that oxygen can flush into their blood, and really hyperoxygenating them and bringing that CO2 down. Right. So note about the MAP, right? If hypoxemia persists despite optimized FiO2 and PEEP, consider increasing the MAP. And that's just what we talked about. Right. So eye times, right? You want to talk a little bit about this, Hunter, or you want me to start with this?
Yeah, sure. I can talk a little about it. So, so with eye time, guys, remember that your IDE ratio is going to be based off your predicted or calculated eye time and your respiratory rate. The manipulation of your eye time and your IDE ratio is going to, for one, when you look at Fick's law, but you also look at mean airway pressure. If you ever look at the equation, obviously it has a lot to do with your PIP and your PEEP, but also has to do a lot with your total time and your total eye time. So prolonging those eye times a little bit and dragging those out, what it does, next time you have a ventilator, put it on a pressure mode and watch it set its pressure. And the longer you hold that pressure, you're giving more time for diffusion of that oxygen. So that's why it's very helpful when we're trying to target a mean airway pressure. If we want a set mean airway pressure, we might want to set that mean airway pressure to a longer time. That way, we're getting maximal diffusion because we're keeping those alveoli for that time. And you'll see that pressure set and it will hold. And as it's held, it allows for that diffusion of that oxygen and that CO2. So manipulation of our eye time or IDE, remember that is our respiratory rate and our eye time, definitely has great effects with oxygenation and mean airway pressures, but it also has good effects with ventilation as well, excuse me. So with our COPD patients or patients that we want to prolong E time, we might have to drop our respiratory rate to give a longer time total for that respiratory cycle, including both I time and E time. So remember that when you have a higher rate, the respiratory rate is divided into 60 over a minute. So that will give you your total time for a breath cycle. And from there, you can buy yourself some time with I to E ratio. And if you calculate that into seconds, this is kind of, I guess, more advanced. But if you calculate it in seconds, you can see how long you're in your I time versus your E time. But again, I don't know what you think, Sean, but there's not huge manipulation with IDE unless you're getting into your ARDS patients and we're talking about the airway pressure and you want to prolong that diffusion state. And or on the contrary, that would be a higher I time, lower E time. On the contrary, with our obstructed patients or patients that we're trying to help exhale, offload that air, we would do an opposite. We'd do like a longer E time, shorter I time.
Yeah. No, I totally agree. I mean, I would say, like, most of the time my eye times are somewhere around 0.9, 0.8 to 1, 1.1,
Sure.
1.2. It's just kind of whatever seems to be most comfortable for the patient. I usually start around 0.9, maybe 1. But yeah, unless I'm trying to manipulate their gas exchange, I don't mess with it too much.
Sure.
Cool. All right. Here you go, buddy. So dead space
So,
ventilation versus shunt. All right, the VQ
so
mismatch.
VQ mismatch. We were kind of talking about it earlier, and we had to hold back there a little bit. But so VQ mismatch, I think it's something we always say. We're like, oh, they have a VQ mismatch, but I feel like I didn't really understand it a whole lot until I got into critical care and stuff like that. So the ventilation perfusion mismatch, you have a high and a low ventilation perfusion mismatch. So a high ventilation perfusion mismatch would be the degree that you're ventilating this patient, but you're not perfusing them well. So we can get the air in, we can try and get the oxygen to where it needs to go, but we cannot get it into the blood system itself. And why we say it's a high VQ mismatch is because it's a number over a number. So if your ventilation number is good and your perfusion number is low, then that means it's a high ventilation mismatch, a high number divided by a low number. So the high ventilation perfusion mismatch hypoxic patients. And I want to reiterate that VQ mismatches is a pretty high percentage of reason that people have hypoxemia. So when you have patients that are intubated for respiratory issues to a degree of hypoxemia, you usually have somewhere a VQ mismatch, whether that's on the ventilation or the perfusion side. Um, so a high VQ mismatch with the patient that has hypoxemia, if you put them on oxygen and increase that partial pressure of oxygen, they'll usually get better. And I say usually. Now, on a low ventilation to perfusion mismatch, where we're not ventilating and we're not perfusing as well there, so that would be like pulmonary embolism, pulmonary hypertension, shunting, stuff like that. So low VQ mismatch would be our shunt. We're shunting away from that dead space, and we're trying to hyperperfuse the areas of the lungs that are participating in gas exchange. Now, those low VQ mismatch, usually a good indicator of them is you put oxygen on this patient, and their SpO2 is not rising. They still have a degree of hypoxemia. So that would be like your pulmonary embolism and stuff like that. Those patients might need to be on a medication to dilate the pulmonary vessels to try and increase that flow to those areas that are not being perfused. They're being ventilated, but they're not being perfused. And then the lung will just stop perfusing that area, shunt away, say, I'm not even going to try it, and go to areas that it can hyperperfuse. So those low VQ mismatches, good indicator of that is putting them on oxygen, intubating them. You're still going to have issues usually with oxygenation, ventilation, stuff like that. They usually need some degree of a medication to fix that perfusion issue that's going on in there. Whereas our ventilation people, pneumonia, stuff like that, the blood's still flowing in that area. So if I can just increase the partial pressure of oxygen and I can just give more molecules of oxygen, hopefully I can go across that gradient. Or like we talked with our Frick's law, we can go ahead and give PEEP, try and pop that open and get it into there. If you're not perfusing that area, like you can see with our dead space and the X over the arrow, we might be getting oxygen, but if we're not perfusing that area, it's never going to go into circulation. So just something you'll want to watch for VQ mismatch. Like I said, a lot of your hypoxemic patients, suffering from hypoxemia are going to have a degree of mismatch, whether that's on the perfusion or the ventilation side. Again, this is where our alveolar dead space comes in. Remember, a physiologic dead space means anatomical and alveolar dead space. Your alveolar dead space now is going to come from VQ mismatch.
Yeah. Right, yeah, and I brought up this slide, right, just to kind of illustrate that point that you were talking about, that hypoxic pulmonary vasoconstriction, right? So when the lung becomes hypoxic, like you said, the vessels, the lungs are smart. They try to shunt blood to the areas of the lungs that are, being oxygenated. And so, there's a really awesome lecture by Dr. Kreger where she talks about um, pulmonary embolisms, and she talks about the use of nitro, nebulized nitro, to actually produce pulmonary vasodilation, as opposed to
Yeah,
all those really expensive drugs, right? Don't do that,
full
right?
man
we're
nitrate.
not
Yeah,
we're not saying to go do that, but but there are some intensivists who, doctors. We're not doctors, but
Yeah.
who have tried that and they've had pretty good results. So kind of an interesting concept, right? If you've got that crashing patient. Um, cool, man. Let's
And
see.
we're scratching the surface right now. I feel like we could just get going into this, but yeah, I think that's the basis of VQ mismatch, guys. Just kind of remembering hypoxemia usually coming from a degree of VQ mismatch. So yeah, I'm reading what Sean said there.
Cool. All right, PaO2 FiO2 ratio. Right, you wanna touch on this?
Yeah, I mean, I feel like we were just chatting about it actually today, and kind of PDF ratio is definitely something we see a lot in the ICU. The degree to get AVGs pretty frequently on these patients. We can do them in the transport world as well, but it's that PaO2 to your FiO2 ratio. Obviously, we have the 300, 200, and less than 150. It's our degree of ARDS, mild, moderate, and severe. I think that the interesting thing with P to F ratios that I always like to point out is if you have the exact same patient A and B on the exact same amount of FiO2, right? They have the same disease process, same amount of FiO2, but one has a worse P to F ratio than the other. You're asking yourself, kind of, how does that work? And I think that's where our implementation of our fixed law and our PEEP is so big. I mean, how can someone have a worse P to F ratio if they're the exact same patient on the exact same amount of FiO2? Well, the answer to that is you're using your fixed law and you're using your mean airway pressures. You're manipulating that system in order to increase that gradient and diffusion of oxygen so that patient's PaO2 is actually better. So just something me and Sean want to reiterate. How you can have that exact same patient that you're just increasing the partial pressure of oxygen. That's fine. You're increasing it above that 21%, but in order to fuse it better, always going back to that mean airway pressure and that fixed law and a couple other things we're going to chat about.
Yeah, totally. Like, one of the examples I always like to say, I had this patient one time. I went into the ER and went to go pick him up, and we were talking about possibly intubating him. And the intensivist who had actually come down was like, "No, there's no reason to intubate him. The patient's PO2 was like 98." And I said, "Okay, yeah, that sounds great, except the patient's on a non-revealer mask, sucking the bag flat. So,
Sure.
you know, they're almost on 100% FiO2, right? And so that P to PaO2 or P to F ratio is like 98, right? If you say the PaO2 is 98 and
Sure.
you're almost on 100%, right? So 98 divided by 1, that's a PaO2 FiO2 ratio of like 98, which is severe ARDS, right? And when I
Right.
was learning this concept, it was like, help me understand this, right? So PaO2, normal PaO2, let's just say 100 for making things easy, and normal FiO2 is 21%, right? So in those cases, your P to F ratio is somewhere in the ballpark of 4 to 500, right? That's normal, right? So now you take that patient with the same PaO2 and but you give them a supplemental oxygen, that ratio starts to change, right? Likewise, we've all seen this, right? That patient who's ahead and they're intubated and they're put on 100% FiO2. You pull a gas on them and their PaO2 is 400. Like, Jesus, they're hyper, they're hyper oxygenated. They don't need that, right? So
Yeah. Right.
that to me kind of illustrated the point when I looked at it and I thought, okay, PaO2 is usually 80 to 100. Normal FiO2 is 21. Do the math. Under normal conditions without supplemental oxygen, their PDF is going to be somewhere around 400. So when that ratio starts ticking down, there's a reason why their PaO2, the oxygen is not diffusing into the lungs, right? And that sets up
Right.
that PDF ratio, which is indication of lung disease. Right? Cool. Good stuff. All right. Management, low tidal volume. I mean, I feel like we kind of touched on this already, but you want to hit that?
Yeah. I we have such a different audience here, guys. So again, this is our introductory with ARDS management. If you haven't heard this already, we're dropping our tidal volume. We can sacrifice CO2 for oxygenation. It's not abnormal to have a lower tidal volume for these patients and to stack their CO2s in order to increase that gradient of oxygen into the alveoli to oxygenate them well. So dropping our tidal volume is very normal. We're not going to get into vent modes yet today, but we will. But this is kind of where we start switching over to our pressure. And we talk about PEEP here quite a bit. And the low tidal volume ventilation is kind of what we're getting at with these ARDS. We're okay with riding their CO2s a little bit higher. Again, we're going to sacrifice that CO2 for our oxygenation, and you're going to see that happens because you're going to try and increase your I time. Well, more time spent in the inspiratory phase, less on the expiratory phase, you're stacking CO2. To be able to do that, sometimes you're going down on your rate and stuff like that. So, and these patients, you start getting really into sick patients, you're going up on their rate, you tend to auto PEEP them, whole lot of thing going on. We're just kind of touching the surface of ARDS right now. And I guess kind of what me and Sean have talked about, which we hope everyone's kind of using those ARDSNet protocol, but it's that difference of those, like I said, that patient A and B. Why do they have a different PDF ratio when they're on the same oxygen with the same disease process? And we're making sure we're implementing PEEP, mean airway pressure, other things like that to increase our diffusion of oxygen. So,
yeah, totally. And yeah, and like Hunter, just said, we're just kind of starting to touch on some concepts that we're going to be starting to dive into in later broadcasts. The one thing, and this is kind of like the transition to our last little phase here, right? So there's a really interesting study where they looked at how do we protect the lungs, when we're doing ARDSNet ventilation, right? And so if you look at this, basically what they found is if we're giving patients low volume and low pressure, this is what's best for the lungs. We still need to maintain their oxygenation, right? So we're doing these low tidal volume ventilations. We might need to increase their respiratory rate in order to maintain that minute ventilation, like we talked about at the beginning, right? In order to maintain their CO2. And this, again, is in that patient who does not have diseased lungs. If we have somebody with obstructive disease or anything like that, then we need to start manipulating that IV, and we might have to stack that stack the CO2 in order to give them enough inspiratory time or let them exhale. The next stage is that low volumes, right? So we're doing low volume ventilation, maybe 6 mLs per kilo, 5 mLs. Hope you guys don't have to go to 4 mLs. But you're increasing their PEEP in order to maintain their oxygenation. This has been shown to not be as bad for the lungs, but now when you start getting into super high volumes, right, where you're ventilating at 9, 10, 12 mLs per kilo without giving the PEEP, that is when we start doing a lot of damage to the lungs. And I'm sure you've all heard about the shearing forces, of the alveoli, the atelectic trauma, but then there's also barotrauma and volume trauma. And the volume trauma is worse than the barotrauma. And I guess if you really want to take this to kind of the next level, high volumes, zero PEEP, that would probably be the absolute worst, right? Because now you're not getting any splinting open of those alveoli. You're going to get that shearing trauma plus the volume trauma. And so this starts to kind of transition into this concept of compliance, which we're going to talk about next week. I just wanted to introduce this, right? We talk about you have to monitor both volume and pressure. If you are volume ventilating, you have to measure or you have to monitor the patient's airway pressures. And likewise, if you are pressure ventilating, you have to monitor the patient's volume, right? And the way I describe this is, let's just say for a minute, we're here and we are volume ventilating, right? So we give a patient with healthy lungs a certain volume, right? The volume goes up, but the pressure only goes up a little bit. You can follow an imaginary line down. As that volume goes up higher and higher and higher, now say we're into that 10 or 12 mLs per kilo, you can see that the airway pressures go up exponentially. And now we could potentially be into that range where we are doing lung damage. Okay, on the flip side of that, still healthy lungs, right? We're talking about these very compliant lungs, very healthy lungs. If we are pressure ventilating somebody, we give them a little bit of pressure and we get a lot of volume. Eventually, if we are over pressure, if we're giving them too much inspiratory pressure, we reach a point of diminishing returns where all we're doing is increasing the pressure without increasing volume enough, and we start to do damage. And we can take this nice compliant lung and turn it into this really poor compliant basketball style lung by overventilating these patients for too long, of course. And this is where this ventilator associated lung injury comes in. So the example for the non-compliant lung, right, is these basketball style lungs is, again, we give them a little bit of pressure, we get some volume, we give them a little bit more pressure, we get some more volume, but we reach that plateau point where we've reached that diminishing return much quicker. And likewise, you can see if we're volume ventilating that same patient, we give them a little bit of volume, goes up a little bit, the pressure, airway pressures go up a little bit, but again, at some point we reach that point of diminishing return where we give them a little bit more volume, the pressures just go up exponentially, right? And so by monitoring both the volume and the pressure when we are ventilating our patients, it's going to give us that ability to tell what's going on in their lungs and determine when we've reached this point of diminishing returns where we cannot give them any more volume or pressure before we're just doing damage, which is perfect for what we're going to be talking about next week. Real quick, we've talked a lot about the concept of if you have managed ventilators, right? There's this idea where we got to keep the plateau pressures less than 30. Otherwise we're going to start doing lung damage, and we're starting to see evidence. It's been out for a while that perhaps the peak inspiratory pressures and the plateau pressures are not quite as critical as we once believed for preventing ventilator-associated lung injury. Perhaps this concept of driving pressure is a little bit more important. So what driving pressure is the difference between your plateau and your peak. So let's just say, for instance, we're ventilating a patient at whatever volume we've set. We do an inspiratory hold, we check their plateau pressures, and their plateau pressures come back at 25. Perfect. Under normal circumstances, we would say that that's safe for this patient. Except, or as I have it drawn in this example, 20. But let's just say, for the sake of argument, 25. But we have our PEEP set at 5. The driving pressure, the difference between those two pressures, is 20. What the evidence is starting to suggest is that if we have a driving pressure greater than 15, that may be more significant for doing lung injury, ventilator-associated lung injury, than just simply having those higher airway pressures. So the question then becomes, what do you do? Do you increase your PEEP? Do you drop your volumes? We're going to get to that next week when we start talking about compliance and dynamic compliance versus static compliance with the respiratory coach. What do you think, Hunter? Do you want me to go back to the driving pressure and talk a little bit more about that? Do you want to add
No,
anything to
no, I think you were spot on. There's been many studies, guys, that they found, like my partner Sean was saying, this difference in these ARDS patients. And again, we want to reiterate that driving pressure is for ARDS patients. That's where it's been primarily studied. And they found this commonality of the P-plat from the PEEP having this sustained driving pressure that we're talking about. And it's been proven to do better with mortality and morbidity. So, like Sean said, it's been out there, but just a concept for you guys to use on your ARDS patients. We're not telling anyone to use it, but just a good concept to keep in your head. And like Sean said, we're going to start we'll start talking about a lot about pressures coming up with the respiratory coach, and we're really going to dive in. So anyone that wants to nerd out, come check it out. It's going to be fun.
Yeah. Yeah. Next week is going to be really heady for me. I mean, you and I have talked about these concepts, and I am picking like little bits of it like out of the air. I'm just grabbing it and pulling it down. I'm like, okay, I got that. Okay, I got that. I got that. I mean, like last time we worked, it was like 2 hours of talking about this. And I'm like, okay, I think I understand the concept. So I'm really looking forward to it.
It'll be fun.
Yeah, it's gonna be fun. Totally stoked about that. That's gonna be Thursday of next week, right?
Yeah, Thursday afternoon, we're gonna have our respiratory therapist friend on here. We're gonna dive in, guys. That'll be a good one to come, and that's a good one if you guys have questions about respiratory stuff. He's gonna be live with us, so I'm sure he'd be more than happy to chat about it.
Absolutely. Okay, guys. There's gonna be a little bit of delay. I'm gonna go ahead. I'm gonna put up the QR code to get the free CE. There's gonna be a little bit of delay, so check it in about I'll just say half an hour. If you're watching this live, check that QR code in about a half an hour. If it doesn't work, try it again. Keep trying. I'm going to keep it up. Once we have everything up and ready to rock and roll, that's when the timer will start. It'll be good for 24 hours at that point. And then it'll come down. So you'll probably have a day and a half in order to grab that free CE. I wanted to just real quick. Nick Chow from Texas, West Texas, had popped in during the broadcast. He says that he is doing his FPC next Tuesday. So, dude, good luck to you. If you have any questions,
love Nick.
Yeah, man, dude, you're gonna crush it. If you have any like kind of last minute questions that you want to bounce off of Hunter or I, shoot us an email. Sean, you can just send it over to Sean@flightcrit.com, and I'll share that with Hunter, and we'll get those questions answered. All right, you guys ready? Here comes the QR code. Let me make sure I hit the right one. There you go. All right, scan the QR code.
You know, yeah. There you go.
And
hop on over to the website if you're watching this on your phone. Hop on over to the website, and like we said, give us a sec, but it should be up relatively soon.
Yeah, heck yeah, and just like hit us up, let us know, what you think about this. If you like these broadcasts that we're doing, let us know. Whether it's in the comment section before or live or after the fact on YouTube, on the Facebook groups. If you're watching it on the website, you can always use the comment page there on the website, or you can just email me and I will absolutely share them with Hunter. We also have a rockin' Instagram page that Hunter's crushing, so that's super cool. Lots of questions there. It's fun. I like it too.
It's a good time. Yeah. Come on, follow the Instagram page, Flight Crit @Flight Crit. We do daily questions. They're topics of everything. For nurses, it's anywhere from CEN to CTRN questions and FPC questions. It's got everything. So come check us out.
Yep, that's right. And then, one last thing. Remember, we have applied for our California Board of Nursing credential. So between now, started last week, and until that credential comes in, could be about 3 months, but it could be a lot sooner. We're the Epic Review course, lifetime access. So if you are EMT, paramedic, flight medic, critical care medic, flight nurse, new grad, nursing student, doesn't matter. If you think that this is something that would benefit you, head on over to flightcrit.com. At the top of the page, you'll find a link for the Epic Review course. Take a look at that. There's you can preview a lot of the topics to see if it's something that you might like. It covers everything for the FPC, CCPC. It's super beneficial for the CFRN as well. Hunter and I are creating new content that's going to be specific CFRN driven. So that's going to be added to the course. And it's just going to keep getting bigger and better. So take a look at it. If you know anybody who is interested in this kind of thing, please share this out. Tell them about it. Word of mouth is the way. We kind of let more people know what we're doing. Invite them to the Facebook group. invite them to the YouTube channel. Whatever is their jam, doesn't really matter. We're everywhere. So that's all I got. You have anything you want to add, buddy?
Nothing else. Thanks for hanging out with us, guys. This is our afternoon one, so thanks for hanging out.
Yeah, for sure. And a good point, right? This is the afternoon, so if you like this time, if you like late, late afternoon, early evening, or if you like early morning, mid afternoon, if you have any suggestions, let us know. Also, if you have any particular topics that you would like us to do a class on, you can go head over to flightcrit.com/live, and I think let me find that one. I'll put it up. Yeah, never mind. Flightcrit.com/live. There's a little comment section there where you can send us a quick message and let us know what kind of topics you want to hear about. That's all I got, buddy.
That's it.
Go.
Thanks for hanging out with me, Sean.
Yeah,
Everyone
buddy.
else, thanks for hanging out with us.
Yep. We'll see you guys next time.